Well, first of all, thank you all so much for being here. I'm super excited about a lot of the discussions that are going to happen today. ASCO can be overwhelming. There's a bunch of exciting updates for many different things. And that's why this, by Formedics, has been assembled, which is the Oncology Forum 2025. You can see by the faces who need no introduction, but we will introduce just for formality on some of the topics that are very important that we're going to cover today. First, we'll be talking about lung cancer. But before we start that, I wanted to bring attention to Figure 1, which is a Formedics property, or basically a means to be able to help oncologists get kind of insights on different cases that can be challenging. You have access to KOLs. It's actually got AI assistance. Leveraging tech to be able to deliver the best care is always, something that's regardless of updates year to year. The collaborative effort on this challenging disease process, I think it's super important and become more democratized than ever. So with all that said, our lung cancer series is sponsored by Merck, and our panelists are shown above. Dr. Millie, who's a clinical professor at Stanford University. We have Dr. Stephen Liu, who's the associate professor of medicine and director of thoracic oncology at Georgetown. And we have Eric Singhi, who has just won ASCO's 40 under 40. So whoop, whoop. Same middle name as myself, Kumar, and he's at MD Anderson. Harold and Kumar movie kind of made things hard for us, but still around somehow. So with all that said, the first thing that we wanted to talk about was some of the updates in non-small cell lung cancer. And the one I get excited about, hence at the top, is this whole concept of neoadjuvant therapy, not just in lung, but in general. We're finding that these progressions and survivals can be improved if you do quote unquote cytoreduction before you do surgery. We're not going to get into the inequity or access issues about how things are still delivered up front. But as we learn things, getting it out, into the open so people get the right management and care is important. But in this case, we're actually talking about a targeted therapy now, neoadjuvant, meaning before the curative, resection of osimertinib plus minus chemotherapy versus chemotherapy alone, which we're pretty familiar with, hopefully, when it comes to patients with resectable, or AKA curative intent, EGFR-mutated non-small cell lung cancer. So I'm going to throw this one up and see who is the most excited about how this combination therapy may look in the pre-resection setting.
Well, I can start. Yeah. So it's always exciting to be able to bring some of these targeted therapies, these more personalized therapies into the early stage setting for our patients. So recently, just a few years ago, actually it made it twice at the ASCO plenary, was the ADAURA update, which looked at adjuvant osimertinib after surgical resection with curative intent for patients. We learned about a disease-free survival benefit. We learned about an overall survival benefit from that setting. And now we're trying to figure out, can we bring it in even earlier, right, to hopefully improve outcomes for our patients. And so what we saw in the NeoADAURA study, which is a phase 3 study, was bringing that oral osimertinib up front, plus or minus chemotherapy. What's it doing for patients before they get to surgery? The major pathologic response was right around 25 to 26%. And that's even with the addition of chemotherapy. So I actually found that a little bit disappointing, to be honest. I was really hoping that chemotherapy was going to make that more of a robust response. But we didn't see it. PCR was around 4 to 9%, so also not a slam dunk. So for me, I'm still leaning towards more of an ADAURA approach. It's important to note that these patients had to have surgically resectable disease deemed resectable before they enrolled on the study. This wasn't to try and convert patients to have more surgically resectable disease. So I think a lot to think about, but for me personally, not practice changing. Stephen, what do you think?
I think a lot of things have to go right for that approach to work. You've got to get the testing in time to start therapy. And there's always a window where someone is resectable, but that window eventually closes. So you don't want to wait too long to get those results. I think that it's an interesting study. The adjuvant approach of 3 years of therapy is giving osimertinib a little bit beforehand, going to make a difference if they're going to be on treatment for 3 years. I don't know. That said, though, I actually am very excited about it. Not so much for practice changing today. And if someone wasn't sure if they had the EGFR mutation or knew it was EGFR, but they weren't sure about starting therapy, I wouldn't consider this a standard approach right now. And I think surgery and then adjuvant chemotherapy or adjuvant TKI is still appropriate. But for me, the reason why this is so important and why this is so exciting is I think this moves us a little bit closer to refining our therapy in a logical, rational way. Now, right now, you're right. The path CR rate and the MPR rates are low. They're not so different from what Colin Blakely and Jackie Aredo showed a few years ago at ASCO. But the real value here is when we give osimertinib, we don't kill all the cancer cells. We kill some. So now let's try to understand why don't we kill all the cancer cells and then develop tools to kill all the cancer cells and maybe put to rest the myth that we can't cure cancer with targeted therapy. I think we can't cure it with today's targeted therapy, but I think that's our goal. And I think we will get there. And these window of opportunity studies are how we learn about how do cells persist? How do they survive despite our best efforts? How do we take that next real step forward?
Excellent points.
And I think this is really just a proof of concept trial as well. I mean, of course, EGFR is, probably the driver mutation that we've been most interested in, higher percentage of patients, but we're now finding lots of other driver mutations in our patients that are present at much lower frequencies. But again, the significance of finding it is that you could offer that patient treatment with targeted therapy. And so we have the Nautica-1 study, which I think is really exciting, looking at other driver mutations. We're going to talk a little bit about ALK, but what do we do in our ROS1 patients or our RET patients? And is there a role for any targeted therapy in the earlier stage setting for those patients? So I think it's great. We know that all TKIs are not the same. They're all different. And we're seeing differences even in these two studies, in the NeoADAURA and the El-Neo study, right? And I think we need to get this data, we need to understand, and we need to learn how to incorporate it into our clinical practice.
Yeah, I mean, these are all just such good points. There's some value, with really first the proof of concept, not some, but huge. Like just saying like, hey, should we be approaching this new strategy? Let's look at it, temper our expectations, but then adapt and pivot to figure out like the what's and the whys and the hows to make sure to get it right. So excellent points, and thank y'all. So you had brought up, and maybe we can start here on the final analysis of alectinib as neoadjuvant, again, treatment in patients with potentially, now that there's a word potentially here, resectable stage 3 ALK positive non-small cell lung cancer. So you were alluding to earlier, no tyrosine kinase inhibitors, these oral pills, none of them are the same. They work differently, different efficacies. But then also what they're working on has different, pathogenesis upstream and downstream. Can you tell us a little about what you either get excited about or, again, does that kind of modifiable, pivoting importance as we explore things in the future when it came to the trial with alectinib in the neoadjuvant setting?
I mean, I think here we're seeing a little bit, more encouraging data where the PathCR rate was a little bit higher here. I believe it was like 12 or 13%. So better than the single digits that we saw in NeoADAURA. So, again, I think this is great. We need to get more data, and then we need to really figure out, is this something that we should be applying for all of our patients? I am excited about the idea of using other modalities such as like ctDNA or looking at other ways of really predicting whether patients are responding to these drugs and how much of the drug they need. And so that's, I think, one of the big pushes forward as we, to really be able to individualize treatment beyond just the driver mutation, but duration of treatment. I mean, how can we decide how long a patient needs to be on a particular therapy, whether or not they really need the neoadjuvant TKI or whether we give it adjuvantly? I think, these are things that we need to individualize in our tumor boards and, and as we discuss with our patients, patient preference plays a huge role here as well, right?
100%.
Yeah, I think that we look at PathCR rates. We want them to be high, but we also have to know that pathologic complete response, its value right now in our current standards in the setting of immunotherapy, where it really predicts long-term survival, maybe cure. I don't know that the same thing applies to targeted therapy, and so we have to prove that PathCR is a good surrogate for survival. And these are early data, so we have to wait and see. Now that said, also very excited about this. I admit I'm probably very easily excited, but I think these are exciting because of that word, potentially. And one thing that these TKIs do is they can shrink cancers. We can get responses, right? We're very confident we can get a response. So if someone has a borderline resectable or frankly unresectable tumor, but if I'd say we can shrink that by 40% within a couple weeks, would that facilitate resection lobectomy? There are bigger questions. Is that actually in the best interest of the patient? Is that better than radiation? I think that a lot of times we assume that it is. I'm a believer in surgery, not just to get us to cure, but also to delay resistance, to remove those clones that don't persist. And a lot of the work that your institution has done in Bright Star and North Star is removing that residual disease. And I do think that delays resistance. I place a lot of value on surgery. My wife's a surgeon, so that's part of it. But I think that there's value. So converting or making someone unresectable, resectable, I know that's not necessarily what a lot of these studies are showing, but I do think there might be some value in that. So I'm excited for that reason.
Yeah, I'll echo that too, Stephen. I think this is different in terms of the study design than what we just talked about with NeoADAURA. One, this is potentially resectable disease, right? That was not the disease that was studied for NeoADAURA. They had to have already deemed resectable disease. Second, this was stage 3 disease. There were earlier stages of disease in NeoADAURA too. And then what we saw was there was a perioperative sort of approach here too in terms of systemic therapy. So patients on this study had to get alectinib for a certain amount of time after they went for surgery. That was not mandated in NeoADAURA. So those are big differences to consider. I'm also very excited about this potential for conversion, for nodal downstaging, for making an impact for the surgeons to make it easier for them to take it out and hopefully improve outcomes for our patients. So I think I ask a little bit of a different question. I'm equally as excited as Stephen, and with the results here, the MPR rates were higher. They were in the 40+% rate for this as compared to what we talked about with NeoADAURA. So we'll see what we see. But for now, yes, I'm excited too.
Yeah, I mean, it's the humility of discovering and kind of surfacing these things, because to what you all alluded to, even if you're able to make it resectable, then the next question is, does it actually change survival? Because if you have this micrometastatic disease, you're able to resect, great job, you lost some lung volume, but you're seeing the recurrence rates that are the same. Now, all of a sudden, again, it could be a humbling, just series of understanding. So with all that said, the data, we're gonna take a little bit of a shift. I don't know if it's tropion or tropion, but it's over the receptor, lung 2, datotumab deruxtecan plus pembrolizumab with or without platinum chemotherapy as a first-line therapy for now advanced non-small cell lung cancer. So we're talking about, advanced, unresectable, stage 4 disease. And if this antibody drug conjugate plus pembrolizumab with or without chemotherapy is an option, because classically, for the most part with stage 4 disease, we just think chemo plus minus, IO if tolerable and no contraindication. Is it something you're excited about? Is it something that, again, is just kind of humbling us and telling us what to focus and not focus on?
I think there's a lot of interest in antibody-drug conjugates across tumor types, including lung cancer, right? So this is exciting. I think this is the largest data set that we have, close to 100 patients getting this ADC in combination with a checkpoint inhibitor. In this study, it was pembrolizumab plus or minus chemotherapy. And what we saw was that this combination is safe. We're not seeing any, I think, unexpected toxicity here. And so, in my mind, ADC is like a targeted chemotherapy. So can we actually replace platinum doublet chemotherapy? That's been in our sort of treatment paradigm for decades now. And so, in this study, they looked at adding also, there were a cohort of patients who also got chemotherapy. The response rate was actually not any higher whether or not patients got chemotherapy. To me, this is encouraging. This means that perhaps ADCs can potentially substitute or replace platinum-based chemotherapy. I think we need larger studies to confirm that, but that's really the goal, is to be able to provide targeted chemotherapy and perhaps kind of shift the treatment paradigm. This is not the study that's going to prove that. This is, again, kind of proof of concept, and hopefully we can move this forward.
Yeah, I'll echo a lot of what Millie just said. Last year, I think there was a session where we talked about how ADCs in our space have historically overpromised and underdelivered. And so there was a lot of excitement this time where we actually saw some of the data, the largest subset, like Millie mentioned as well, this triplet versus doublet. That's not really what this was looking at, specifically comparing those two. But I'm more excited about the doublet, to be honest. The response rates were very good. In terms of toxicity, we did see stomatitis. That's something to definitely make sure we're counseling our patients on, making sure we're supporting them. With regards to also thinking about how we can better direct this treatment, right? We're thinking about an AI, you're the king of AI, but an AI sort of proven biomarker against TRP2. We saw that there was increased enrichment. There seems to be a better suggestion that this is going to be more efficacious for patients. So I'm looking forward to it. A lot more work still needs to be done, but there is some excitement. I am excited. Stephen?
Yeah, I'm excited too. I feel silly just saying I'm excited about everything. But
He's always excited.
I'm excited for different reasons. I think that first, we really got a little bit more at closer look at this biomarker, which we saw at WCLC from Marina Garacino. Ben Levy presented it this time. And really, this AI-driven biomarker, it's a rational biomarker that really fits with the way that the drug works. That it's not just binding, it's internalization. That's important. We need a way to measure that. So it's a logical biomarker. I think there's a lot to be said for that. And we saw outcomes were much better in those that were biomarker positive with a lower NMR score. Now, as Eric said, this is really important. It was doublet, triplet, and yeah, the numbers for the triplet didn't look as good as the doublet, but it was not a randomized study. This was really showing the feasibility, the potential, the toxicity, the safety. That's really what this study looked at. There were different cohorts, there were different patients, more brain mets, different doses used. These are not meant to compare. The reason I'm excited is that when we look at what ADCs can do, if ADCs are going to replace docetaxel, if ADCs are going to replace chemotherapy, that is, I think, at best, an incremental advance. The real advance is if there's the potential for long-term survival, right? We've bitten the apple. This is what we want for our patients. We want them to be cured. We want them to be long-term survivors. The only way we get that today is with immunotherapy. And so anything that could help immunotherapy get there. Anything that can facilitate or make more likely an immune-mediated anti-tumor response is going to be of value. And could ADCs be an upgrade? Could they be better partners than chemotherapy in getting us to that immune response? Not just holding off disease to let immunotherapy work, but letting immunotherapy work more likely by, targeting suppressive tumor cells or T cells, by disrupting the microenvironment, that architecture, using the bystander effect to allow our T cells to get access to it. And I think that it really could. So that will manifest not in a higher response rate, not in a better PFS, but a better long-term survival, elevating the tail. That's really what we want. Other forms of chemo are not going to get us there. ADCs could get us there. And that's why I think these phase 3 randomized trials will be so important.
No, it's such a good point. I mean, you want this antigen presentation, you want, immunotherapy to do what it does well. And that's where this question of combination or multi-agent therapy versus not is one, kind of thought about early on, but then two, to your point, the long run. Like, did it present, is this multi-shot, multi-mechanistic approach, does it permit your body to really have these deep responses? And that's just so exciting. And then when TROP2 is, obviously something that's available in multiple malignancies, now you're just kind of really opening the box on where you could kind of see this benefit up front. I mean, the thought of using platinum in non-small cell lung cancer as a second-line therapy is crazy. I mean, just even the thought of saying that is something that's hard to, wrap your mind around.